Our patient was an 81-year-old female diagnosed with normal pressure hydrocephalus, or NPH, which was treated with the placement of a VP shunt in 2018. NPH results from the brain's inability to absorb cerebrospinal fluid, which increases the pressure in the skull. And then to accommodate this increase in pressure, the ventricles in the brain enlarge. So to decrease the dilation of the ventricles, a shunt is usually placed to allow the CSF that is not reabsorbed to drain. This condition usually results in impaired bladder control, an apraxic gait, and usually a mental impairment. Our patient also has a history of seizures and hypotension with positional changes, and her condition is also monitored with various medications that work to maintain her intracranial pressure.
As we look into our client's contextual factors, we have to consider her personal factors such as age, her responsiveness, and cognitive function. We also need to consider her motivation to improve her function, which contributed to her commitment to perform any home exercise plan given to her. Her environmental factors include her familial support from her daughter and grandchildren who live with the client and help manage her medical condition. She lives at a 2-story home with her bedroom on the 2nd story and a railing on the right side. She also likes to visit her grandchildren who have a dog.
The tests and measures performed in TAC were based upon patient responses in the subjective portion of the exam, and especially her past medical history. Due to her hydrocephalus and shunt, our patient has gait disturbances and mental impairments, as well as orthostatic hypotension. In order to test if her range of motion, strength, balance, fall risk, endurance, and coordination were affected by her impairments, the listed tests were performed. The Berg scored our patient as a high fall risk. The 5-time sit-to-stand showed that our patient was slow with transitions and had poor eccentric control. The 4-square step test showed poor dynamic balance for the patient, and she self-reported fears of falling during the test. Range of motion was performed at the cervical region, since she reported pain in the cervical region in the subjective portion. Finally, strength and range of motion was performed at the hip to see if this was a contributing factor to her balance and coordination issues.
For telehealth testing, we did the 5-time sit-to-stand test. The patient averaged over 3 trials, 27.6 seconds. This was above her age range norm, and she presented with dizziness after the 2nd and 3rd trials requiring breaks. The timed up and go test, the patient had notable slowed movement during the transition and also during the turning. It had wide step pattern and took 3 to 4 seconds to turn. Upper extremity active range of motion testing demonstrated that the patient was within functional limits. However, they did report that the patient had difficulty with overhead activities and showering, and also tested was the frequency of stops during dual task ambulation and math prompting. So the patient stopped a total of 4 times to divert those attentional resources towards answering the math questions instead of ambulating like she was supposed to. On the activities-specific balance confidence scale, ABC scale, the patient scored a 62.5% on confidence, which qualified as a moderate level of physical functioning. Within our clinical decision-making for telehealth, we found that we can work towards increasing momentum use and center match progression of pervasive support during sit-stand transfer. We can increase confidence during ambulation instead of fear of falling. We could increase the arm endurance for functional overhead activities during showering. We could also increase the ability to divide attentional resources during ambulation.
The most important impairments recorded during TAC were lower extremity weakness of the client's left side, impaired static and dynamic balance, difficulty dual tasking, limited cervical range of motion, as well as painful upper extremity range of motion at end range. The linked activity and participation impairments include the inability to drive because she is unable to view over her shoulder, unable to maintain attention required for driving for long periods of time, and has slower reaction times. She is not able to go on long-distance walks due to her balance deficits and her weak left lower extremity. She also has difficulty ambulating stairs in a normal period of time because of her balance deficits, fear of falling, and once again her weak left side.
Our goals when working in TAC were focused on improving our clients' balance, gait efficiency, fall risk, and functional activities, which require strength in her lower extremities and range of motion in her cervical spine. Our client's long-term goal was driving, so improving her ability to dual task was also addressed.
Our goals for our client during
To address
Our goals for our client during telehealth were mostly based upon the shortened time frame we had during the 2-week intervention phase of treatment. The first goal was based upon making her sit-to-stand transfer more efficient by having her bring her shoulders over her knees in order to shift her weight forward and make the transfer easier for the patient. This was noted difficulty during testing, so we wanted to focus on it during our telehealth visits. The second goal was having the patient perform mental math during gait in order to improve her dual task ability, since her ultimate goal is to return to driving her car. The third goal was centered around improving her ability to wash her hair while showering by using a PNF pattern to increase shoulder flexion and overhead strength. Finally, during the timed up and go, it was noted that the patient had trouble turning around with efficiency, so our gait exercises focused on having the patient not only ambulate safely and efficiently, but also turn safely and efficiently.
To address our client's goals, we started by working to improve the strength in her lower extremities as a foundation for other activities we would include later on in her treatment. These activities included sit-to-stands with proper form to improve community participation and strengthen the major muscle groups of the lower extremities. Box step-ups were also used with a focus on adequate weight shifting from side to side and proper weight acceptance when descending. Lateral reaches were performed with a stability ball to improve frontal plane pelvic motion and elongate her thorax to improve arm swing during gait. And as we progressed to more difficult activities, clock stepping was used to improve her ability to step in multiple directions as well as strengthen her lower extremities in multiple planes. I won't read all of the progressions and regressions for you guys, but if you're interested in what we did, they are listed in the tables. About midway through our first term in TAC, the strength in our patient's lower extremities really started to improve. And with a proper foundation, we were then able to switch our focus to more dynamic activities. So PNF was a big part of many of our treatment sessions. Combination of isotonics was used to improve her gait by increasing her body's ability to correctly fire the muscles in her lower extremities in the proper sequence and kind of turn on the muscles she wasn't regularly recruiting. These were mainly her ankle plantar flexors and dorsiflexors, as well as her hip stabilizers. A slow reversal technique was also used in bridging to again recruit the muscles her body was not regularly and adequately firing. Balance activities were also used to improve her ankle strategy and increase the use of her proprioceptive system instead of just relying on her visual system. An obstacle course was done during a few of her therapy sessions as well to simulate what it might be like to navigate obstacles and uneven ground when she was out in her community. These included different obstacles which she had to step over, as well as multi-directional stepping and different surfaces she had to walk across. Overall, we are very fortunate to have a client who came to TAC every day motivated and ready to try anything we thought would help her improve, so that played a big role in her interventions with us.
For telehealth interventions, the first was a D2 upper extremity flexion active range of motion against gravity pattern. This was regressed with complete in-mill movements with 3 different parts: first flexion, then abduction, then external rotation instead of the one fluid movement, or decreasing the reps and taking rest breaks. That was progressed with changing the position to standing and including hand manipulation by holding onto a TV remote or some other light resistance. The goal was to increase bilateral overhead arm endurance strength for functional movements during showering, and the patient did report increased overhead endurance and less tiredness, so this met the goal. The second was sitting to standing transfers with an emphasis on driving the shoulders over the knees. This was regressed with separating the 4 parts of the transfer, so between phases 2 and 3, taking a break. It was progressed by having no stops and doing one fluid motion, and the goal was to demonstrate this progression of center mass over base of support and using the momentum, and the patient did demonstrate this at the last session, reporting decreased energy spent during movement. We continue with a diagonal and side-stepping ambulation exercise, which is regressed with the inclusion of breaks and decreasing the length of the walking. We progressed it with increasing the time and duration of up to 5 minutes in these directions, and also increasing the frequency of the walking. Our goal was to increase the patient's confidence during ambulation and also to increase the weight shift and step length. The patient did report an increased confidence in walking at last session. Next, we had the ambulation with mental math exercise. We regressed this with a decreased use of multiplication and division, instead focusing on addition and subtraction math. We progressed it with decreased use of addition and subtraction, then focusing more on that multiplication and division math. Our goal was to improve the dual task attention during ambulation, and between the third and fourth visit, the patient actually decreased the response time by 2 seconds, and also decreased the frequency of stops by 2 stops.
Retesting following the first half. Retesting following the first half of the semester was not performed as it was planned due to the switch to telehealth and the accompanied safety concerns that would arise performing outcome measures through telehealth. There were some encouraging observations seen by the end of first half of TAC, though. Our client showed the necessary balance to reach down and pick up an object off the ground, which she previously was unable to do. She also had a more fluid gait, highlighted by a better weight shift onto her left side and greater hip mobility throughout gait.
For telehealth retesting, myself, Ian, and Dr. Udovich, which is our faculty advisor, recognized that formal objective testing wasn't really realistic given the short window span of our sessions, so we really focused on the subjective patient reports and intervention performance to gauge the functional improvement of the patient. And below are the talking points that I had talked about previously in the intervention slide. They're just reiterated below.
Strengths of our plan of care include its ability to keep our client engaged throughout treatment. The interventions utilized were creative and in a fun, game-like manner that kept our client willing and motivated throughout treatment. Another strength of the treatment was how goal-oriented it was. The interventions used directly correlated to the impairments causing activity and participation limitation. These include balance training, step ambulation, gait training, and interventions focused on attention processing.
When thinking what else could have been done, or what could have been done differently, the best thing would have been performing all the session hands-on in the TAC clinic. Since this was not an option, we would have changed a few things for telehealth. The main change would have been preparing the patient and caregiver more prior to each session. By calling them in advance, running through the treatment session plan for that day, and making sure all equipment and space was available, there would have been less downtime and more available time for treatment. Then, for the TAC experience, the biggest change would have been to challenge the patient more. By the end of the first sessions, the patient at one point was able to bend down and grab something off the ground. This was something that we thought would have been too challenging for her, but she did with ease. We would have added perturbations, used less support while still maintaining safeguarding, and overall challenged the patient more during her balance by adding in dual task activities. We used a few forms of group communication over the semester. The first was talking after class, after the first group had been in TAC. We were able to learn about the patients, hear what they did and what they hoped could still be accomplished, and overall how the experience worked for them. Then, when we went to telehealth, we used Facebook Messenger as our main form of communication, since we could quickly bounce ideas off of each other and just check in as a group. Finally, we utilized video chat a few times in order to strategize the project and make sure all audio and information was accounted for.
Changes made to our clinical decision-making would have been retesting the outcome measures at the end of our sessions to have a clear indicator if our client met her goals. We did use clinical decision-making to eliminate interventions involving rapid head movements because they've reproduced headache symptoms. We decided that activities with quick head movements were not necessary for the improvement of overall function. Factors limiting our patient and our decision-making include how our patient would experience dizziness and headaches more so than other days. Our client revealed on the very last day of treatment that she had a few limitations in activities of daily living due to her pain in her upper extremities, in which she had never mentioned before. We must improve on our patient communication and be more thorough in the future.
When reflecting on telehealth, there were some changes to the clinical decision-making that we had to do. We only had 30 minutes per session compared to the longer in-person sessions. We had decreased use of formal testing and increased focus on subjective reports for functional improvement. And then there was some other factors that limited our clinical decision-making that included the lack of physical SPT presence in the room. Some recommendations for the next semester would be to increase the time of each session if it is still on the telehealth platform, or have the client meetings be 2 times a week so more time can be dedicated to interventions and outcomes. In both forms, you saw TAC. In both forms, you saw TAC with our patient as a success. In the clinic, we saw small improvements in gait, increased lower extremity strength, and small improvements in dynamic balance. While in telehealth, we learned and gained experience about telehealth itself and witnessed small improvements in the patient over the 2 weeks of interventions. Overall, our future goals are focused on getting the patient back to driving, continuing to improve her balance, and allowing her to continue her ADLs by strengthening upper and lower extremities and cervical range of motion.